public sector mental health crisis, and how serious is it? This is an area, of course, that involves so many people, not only the people with mental health problems, but of course their friends and their families. And we understand that there probably is a very serious crisis. But in order to help us make up our mind about that, we have two really excellent speakers, and I'd like to introduce them in the order in which they'll speak. The first speaker will be Sebastian Rosenberg.
Thank you all. I think this is the third time I've had the pleasure of being part of Politics in the Pub, and I really appreciate the invitation. Also, thanks for your acknowledgement of the Aboriginal people. I'll spend a bit of time talking a bit about the application of mental health and of the implications of our mental health crisis on the Aboriginal community. I'd also just quickly like to acknowledge what a privilege it is to share the stage with Alan Rosen, Professor Alan Rosen, one of the leading lights in the establishment of a genuine community-based system of mental health in New South Wales. Unfortunately, this was around about 30 years ago, and it's been progressively dismantled ever since, but I think now sits very much front and centre in our thinking about mental health reform. My talk today will be in several sections. The first section will be about Australia's mental health crisis. There's no shortage of evidence, as you'll learn, about the depth and breadth of our crisis, and it has persisted for decades. The second part of my presentation this evening will really focus on momentum. It's my contention that Australia is further from genuine mental health reform than it has been for a decade. This is partly because of a confusing array of policies and strategies and programs. There is in fact an important clash of themes in Australia's attitudes to health and welfare that I think is shaking mental health to its core. And the last part of my talk will really focus on this core. For many decades, the real core of Australia's mental health service has been the public services provided largely by our state and territory governments. The past decades have seen the general dismantling of the community mental health system Alan here did so much to create here in New South Wales. Services have been withdrawn from the high street to the hospital campus. The latest string of policies and approaches are now re-emphasising community mental health over hospital, early intervention over crisis, and individualisation over population-based approaches. These themes have massive implications for our valuable public mental health services, and I intend to explore these this evening. Alan and I were both contributors in 2013 to a report called Obsessive Hope Disorder, which catalogued 20 years of reform and failure in mental health. It also demonstrated that there had been more than 30 separate statutory inquiries into mental health just in the period 2006 to 2012. As I said, the breadth and depth of Australia's mental health crisis is well documented. The overall failure of Australia to invest in a genuine and vibrant model of community mental health has led some to even call for re-institutionalisation. Hey, they might have been locked up, but at least they got 3 square meals a day and a hot shower. This mentality often ignores the horrific abuse, human rights abuse, which characterised institutional care. And look, while I'm using the past tense, it's worth noting that New South Wales still runs 5 standalone psychiatric institutions. There are in fact 17 nationwide, offering 1,831 beds and providing 590,000 occupied bed days at a cost of around $900 a day. Australia is still allocating more than $500 million a year to asylum care. So let us consider some of the key evidence suggesting the seriousness of this crisis. Nationwide, resources are concentrated in expensive acute care services, and too little is directed towards support that helps to prevent and intervene early in mental illness. In New South Wales, around 54% of total spending is directed towards acute mental health services, with 36% spent on what is called community mental health. However, this latter figure is in fact dominated by hospital-based outpatient services. Spending on community services, real community services, is actually much closer to only around 20% of total mental health spending in New South Wales, with NGOs, non-government organisations, accounting for only around 6%, with the balance spent on what is left of community mental health teams in the public sector. So we have an 80-20 rule in play, but it's the wrong way round. Spending on mental health focuses very much on postvention, with services designed to intercede only once a person is very unwell. In cancer terms, we wait for the lump to become large before providing any treatment. It is poor care and poor economics. Total mental health spending in Australia is about $14 billion per year. Of that total, the Commonwealth spending is about $9.6 billion. The rest is spent by the states and territories. And 87.5% of the Commonwealth spending, including income support and funding for acute care, is in demand-driven programs, such as income support and acute care. So this means that the strongest expenditure growth is in programs that can be indicators of system failure, those that support people when they are ill or impaired, rather than in areas which prevent illness and will reap the biggest returns economically, enabling people to participate and live productive, contributing lives. 60% of Commonwealth expenditure, which is just under $6 billion on mental health, is through income support, predominantly through the DSP, the Disability Support Pension. The income support system is also the area of greatest growth in spending on mental health and is currently projected to remain so. There are an estimated 9,000 premature deaths each year among people with a severe mental illness. The gap in life expectancy for people with psychosis compared to the general population is estimated to be between 14 and 23 years. In 2003, there were 2,214 suicides, and in 2013, there were 2,522. An estimated 65,000 Australians attempt to end their own life each year. Suicide is the leading cause of death among people aged between 15 and 44 years old, and is more likely among men, Aboriginal and Torres Strait Islander people, and people living outside of major cities. By comparison, a national multimodal campaign has seen the road toll decrease from 1,621 in 2003 to 1,193 in 2013. The mental health needs of Aboriginal and Torres Strait Islander people are significantly higher than those of other Australians. In 2011-12, 30% of Aboriginal and Torres Strait Islander adults had high or very high levels of psychological distress, almost 3 times the rate of other Australians. And nationally, there were 22.4 suicides per 100,000 Aboriginal and Torres Strait Islander people during 2012, which is more than double the rate of the general population. Aboriginal and Torres Strait Islander people aged 15 years and older report stressful events at 1.4 times the rate of non-Indigenous people. And people with mental illness experience poorer outcomes not just in health but across a range of domains. People with a psychotic illness have diabetes at a range of 3 times that of the general community, and half have metabolic syndrome as a side effect of their prescribed antipsychotic medications, increasing their risk of cardiovascular disease and diabetes. Of people experiencing mental illness, 20% use alcohol excessively or have a drug addiction. The use of antipsychotics has more than doubled since 1990, even though the prevalence of psychosis has not changed. In addition, in 2011, Australia ranked second in an OECD comparison of antidepressant consumption, behind only, any guesses?
England?
Iceland.
Wow.
Long winters? I should say that study does not include the USA, so I think the USA could easily be more. But for social and economic outcomes for people with a mental illness, there are also significant ramifications. 37.6%, or almost two-thirds, more than two-thirds of people with severe mental illness are unemployed or not in the labour force, compared to only 22.3% of people without mental health conditions. About a third of people living with psychosis complete high school, compared to more than half in the general community. There are also, of course, terrible outcomes for people with mental illness in relation to the justice system. Of 29,000 people in prisons in Australia in 2012, it's estimated that 38% of them had a history of mental illness, a rate almost twice that seen in the general population. In New South Wales, the annual number of police incidents involving people with a mental health problem increased by 25%, from around 22,000 in 2007-8 to around 30,000 in 2011-12. Across Australia, over the 11 years from 1989 to 2010-11, 42% of people shot by police had a mental illness. In relation to the state of New South Wales, it's worth noting that the percentage of population seen by public mental health services was 1.6% of the total population in 2006, and by 2011 that rate had not changed. Now, what's curious about this is that the number of FTE, full-time equivalent staff, involved in direct care increased by roughly 30% over the same period. It is for this reason that some people, including me, really reject the idea of simply spending new money in mental health on old systems. So all of this adds up to an enormous economic cost to Australia. The estimates range up to $28.6 billion a year in direct and indirect costs, with lost productivity and job turnover costing a further $12 billion a year. Collectively, $40 billion a year, or more than 2% of our gross domestic product. The OECD estimates that the average overall cost of mental health to developed countries is about 4% of GDP, including intangible costs such as the costs of reduced well-being, emotional distress, pain and other forms of suffering. In Australia, this would equate to more than $60 billion, or about $4,000 for each person who lodges a tax return. And I think I've already pointed out that most of the costs of mental illness are, of course, not incurred by the health sector. Instead, they are costs to employers and to society at large. Mental illnesses are the leading cause of the non-fatal disease burden and account for about 13% of Australia's total burden of disease. This means that the non-fatal disease burden is actually up at 24% and was lost. 24% of the total non-fatal disease burden is accounted for by mental illness. So mental health really impacts not only on the individual and on their families and on other people providing support, but also the standard of living of every Australian and indeed our communities more broadly. So look, it's about this time with all these facts and figures you start to wonder how on earth we got into this mess. And this is particularly so given Australia led the world in the development of national mental health policies and plans. Since 1992, we have had 2 national mental health policies, 4 national mental health plans, 1 roadmap, 1 national action plan, several suicide prevention plans, 2 report cards, and now a National Commission review.
And a partridge in a pear.
And look, all of that activity couldn't be multiplied by 9, because I've really just talked about the Commonwealth things, but of course there's 8 states and territories. So you could have 9 suicide prevention plans, you could have 9 mental health plans. There are 9 mental health plans. And then of course I could be diabolical and say, well, cross out the word mental health and put drug and alcohol. Or put Aboriginal and Torres Strait Islander social and emotional wellbeing, you have 9 more. There are many other versions. It's an industry in itself. It's fair to say that ever since Australia developed the first National Mental Health Plan, they have been becoming increasingly less relevant, with no targets, no incentives, no rewards and no sanctions. In response to the recent National Mental Health Commission's review into mental health, which was, as you may know, first leaked and then released by the government, Minister Susan Ley has said almost nothing so far, except to commit the nation to a 5th National Mental Health Plan. Minister Ley also categorically ruled out the only recommendation which attracted any particular controversy from the National Mental Health Commission's review, which was the idea of gradually moving any Commonwealth-funded hospital growth funding from hospitals to the community sector. Remember, the National Commission were told to make recommendations which did not call for any additional funding. By the way, mental health is about 13% of the burden of disease, as I mentioned to you, but it gets around about 5% of total health funding. So momentum for reform reached its apotheosis in 2006 when, spurred on by several reports outlining Australia's national mental health crisis, John Howard and Maurice Iema jointly placed the issue of mental health on the Council of Australian Government's agenda. And from this action arose $5.5 billion in new funding. And importantly, at this time, while this was clearly a lot of money, John Howard said that fixing mental health would not be a quick one-off job, but would require repeated efforts. Largely, those efforts have not eventuated. Since 2006, in fact, mental health share of overall health spending has actually been declining, not increasing. And in truth, each jurisdiction did whatever it wanted under the COAG National Action Plan on Health. New South Wales spent half its $900 million investment on the construction of the new Long Bay Forensic Jail. The mental health sector waited after the Abbott government was elected, all through 2014, for the National Commission to complete its review. This was handed to the government on the 1st of December 2014 and did not see the light of day until April 2015. The Abbott government has also chosen to remove the Commission from the Prime Minister's portfolio to the Health Department and had put in a trusted bureaucrat to run the thing. It was never set up with particular independence, but whatever it had was now further compromised. The government has now palmed the Commission's review to a new expert reference group and added some new COAG committees to help develop a 5th National Mental Health Plan. The bureaucrats are firmly in control, as they really have been all along. The rash of jurisdictions choosing to construct mental health commissions does not appear to have threatened this control. All in all, momentum around mental health reform has not only stalled, we're in real danger of going backwards. But while mental health may be stuck, health and social policy is not standing still. There are some jarring themes emerging with, as I said at the start, some potentially massive impacts on the way mental health services are designed, provided and funded. There is increasing interest in hospital avoidance generally, with the acknowledgement of the high cost of admissions for chronic conditions. It's difficult for mental health to catch this wave of interest with such a high level of current dependency on hospital-based care. More generally, there is a massive problem with governance in mental health, in that it is precisely in the area most integral to reform, community mental health, where governance of the system is at its weakest. While the states run hospitals and the feds run primary care, neither owns community mental health. It is hard to see how services providing alternatives to hospitalisation for mental illness can emerge in these circumstances. The National Disability Insurance Scheme is partly responsible for this push towards hospital avoidance. There is a focus on reducing the lifetime cost of the scheme. Key people here are actuaries. They can see the benefits of early intervention, crisis avoidance, vocational rehabilitation and so on. But the scheme is in its infancy and there'll be a lot of rules to sort out about eligibility. There are other key themes which add to this confusion. While the mental health likes to concern itself with the concept of recovery, the NDIS and the broader welfare sector have traditionally been focused on maintenance. How will the episodic nature of mental illness fit into this paradigm? There seems to be some similar paradigm clashes between those pursuing early intervention and those more concerned with effective crisis response. While 75% of all mental illness manifests before the age of 25, only 13% of young men with mental illness last year got any assistance. Our system is not designed to meet the needs of young people. Our hospitals are full of people with a mental illness who would be better off in other places if only there was somewhere for them to go. Yet there are some who persist in suggesting that more hospital beds is the answer to all questions. There's also a tussle going on between individualised approaches to funding and other approaches. Activity-based funding seems to have fallen by the wayside, and the federal government has recently decided not to pursue implementation of the National Mental Health Service Planning Framework. Many reports have noted the inequities which characterise resource distribution in mental health. We have a lumpy, unfair distribution of inadequate resources. It's difficult to see how individualised approaches to funding will address this issue. So the picture I think I've painted of the crisis is deep and pervasive, and leadership and appetite for mental health reform is as weak as it has been for the past decade. There's no governance or plan to build a vibrant community mental health sector, leaving us stuck with little or no service alternatives between the GP and the locked psychiatric ward of a general hospital. There is a confusing set of jumbled policy themes making it hard to chart a course forward. Look, I've been given the 5-minute signal, but look, I can't leave you like this. I can't leave you like this, not in this state. It's too grim. So I want to leave you with a short summary just of some alternative ways of organising and arranging sophisticated contemporary mental health care. There are other places striving to build contemporary models of care, and they do not look like what is happening in Australia. The first is Trieste, and Alan can tell you a lot more about this. I think he may be the unofficial mayor of Trieste in Italy. But for a town the size of Canberra, they have only a handful of acute mental health beds in their hospital. They released everybody from their town's asylums, patients, nurses, psychiatrists, families and others, from the constraints of the institution and into the heart of the community. There are several multidisciplinary community mental health centres like those coincidentally recommended here by the Australian Senate in its report of 2006. There are supported employment opportunities and competitive businesses run with and by people with a mental illness. I stayed in a hotel run as such a business. But perhaps at least as important as the practical changes in Trieste is the fact that, as a whole, the town embraced the moral, ethical and practical good sense of this service redesign. Is Sydney like that? I next want to talk about Tupu Ake, a beautiful kauri wood house in South Auckland, which is a consumer-operated acute mental health care unit operating as part of the county's Manukau Health District. It has 10 beds, with each guest having their own comfortable room. The service is run by peers. Tupu Ake operates as an alternative to acute hospital admission for people who, as used to be talked about, were floridly unwell. Health professionals, including psychiatrists, make appointments to meet with guests to review their care. People generally stay about 10 days. Lastly, I want to tell you about Linwood House. Linwood House is an example of a Victorian prevention and recovery care service. It provides brief, sort of 1 to 3 weeks type intensive residential recovery care. The target group is adults requiring more support following an inpatient admission prior to returning home, or for those who are at risk of relapse, where participation in the program could prevent that relapse and prevent hospitalisation from occurring. Linwood House was established and run by ARAFME Mental Health Carers Group in 2004, working in association with the Eastern Health Local District. It continues to operate as a joint venture between the Local Health District and Mind Australia, a large NGO specialising in psychosocial rehabilitation. It offers the kind of step-up, step-down service which is practically non-existent in New South Wales. I could provide you with several other examples, but including the odd highlight from our sunburnt shores, but why bother? Australia has a long, proud history of piloting programs and running evaluations to show effectiveness, only to then defund. It's a joke. Perhaps the main issue arising from even the few examples I've given tonight is that the future of public mental health services cannot look like the past. New money into old systems is a moribund approach. Our workforce is sapped of morale and is ageing. I understand the average age of a psych nurse is around 55 years. And look, who could blame them for feeling abandoned and without much job satisfaction? Their jobs are characterised by failure and blame. They get someone stable in their short period of admission, organise their medication and discharge them, and then we'll see them again in a few weeks. Who would want to work in a health service where you found it so difficult to feel as though you were actually helping? What would make someone want to work in mental health? We must ensure that people associate their roles with success and achievement, helping people stay at home, find and keep a job, manage their physical health and their personal relationships. This sounds rewarding, but it will also require some new thinking about the way our public mental health services are organised. This focus on success serves another purpose. I can't help but think that successive governments' general unwillingness to invest in mental health is partly inspired by their lack of confidence in the merit of the spend. We don't need more celebrities coming out. We need mass proof that good mental health helps people complete their studies, find and keep a job, become good parents and grandparents. The public mental health services of the future will need to work in close partnership with other organisations. Clinical and psychosocial staff will need to cooperate. They may share the same skills accreditation processes to create new understandings, as they do in New Zealand. They may also share intake and assessment forms and processes. They may need to share information to effectively mitigate risk. The workforce challenges here are great, to ensure people are enabled to work at the top of the scope of their practice. There must be new roles for peer workers and others. One thing is completely and utterly clear: we cannot lose the skills and experience we have in the public mental health system. We need to build new and more effective ways of harnessing these skills so they can be used to prevent admissions to hospital rather than just manage them. The models I've outlined today could be part of that new future, but can we please get started? I'm sick of waiting. Thanks.